Hi, I'm Michele Talley. Today we're going to go through diabetes treatment options, oral medications, and injectables. Let's go ahead and get started. First, we're going to talk about oral medication drug classes. We're going to go through several of these drug classes in a little bit more detail with each of the subsequent slides. As we go through the drug classes, I will talk a little bit about the drug class itself, including common medications that fall within that drug class. I'll also talk about advantages and disadvantages to the use of these medications for treatment of diabetes. I'll also talk a little bit about the cost associated with these drug classes. So as we go through the drug classes, you'll notice that we'll use a lot of abbreviations, and that's because otherwise it's a mouthful to get them out every time we say them. So I'll have them identified here on this slide, and then I will abbreviate from here on out. So the first drug class we'll briefly touch on are Glynides. We'll also touch on sodium glucose cotransporter 2 or SGLT2 inhibitors. We'll talk about dipeptyl peptidase 4 inhibitors or DPP4. We will talk about sulfonylureas as well as the thiazolidine diones or TZDs. We'll talk about the Glynides, the alpha glucosidase inhibitors, the amylin mimetics, and the glucagon-like peptide 1 receptor agonist or GLP-1 RAs. Let's start with the Glynides. Metformin is currently the gold standard for treatment of type 2 diabetes. It acts to reduce glucose production by the liver, and it increases insulin sensitivity in the tissue, and it improves the glucose transport into cells. It is an oral medication. It's used, again, it's a gold standard initial treatment for type 2 diabetes along with diet and exercise regimens. It does have some potential benefits for its use, including that it is neutral in heart failure patients, and we've also seen some potential benefits that it can have with atherosclerotic cardiovascular disease or in patients who have that atherosclerotic cardiovascular disease condition or conditions. It is weight neutral initially upon prescription or initiation of the drug. Some patients may see some modest weight loss or minimal weight loss, but then that usually subsides after about 3 months of use. The common side effects included in the use of metformin include gastrointestinal side effects like nausea, vomiting, and diarrhea. These are very common. In fact, it's very good to educate and warn your patients that this will occur or may occur in them with any increase in dosage or frequency of the metformin. There is a potential with a vitamin B12 deficiency associated with metformin, and there will be hospital protocols that will be developed, usually related to holding metformin prior to or after any contrast dye due to the interaction it has with the renal function. So it is also contraindicated in patients who have an estimated glomerular filtration rate or EGFR of less than 30. It's important to note. And there's also a very low cost associated with metformin. In fact, many pharmacies in the U.S. offer this for free, or others offer at a very low cost per month. So let's talk about the SGLT2 inhibitors. The drugs that fall within this class block glucose reabsorption by the kidney. We have several medications that are listed here. We have the canagliflozin, the dapagliflozin, empagliflozin, and the ertugliflozin. And these are all oral medications. They do have some benefits, which include weight loss as well as lowering blood pressure. So you can see that empagliflozin and the canagliflozin are good for the atherosclerotic cardiovascular patients and heart failure patients. And dapagliflozin is good to use in heart failure patients as well. There are some adverse effects associated with the SGLT2 inhibitors. Those include the genital infections, urinary tract infections, volume depletion. And let me stop there and say that because of the way that the drug works, it blocks glucose reabsorption by the kidney, so it causes the glucose to exit through the genitourinary tract. As it does that, it does increase the risk of infections, and that's why you see the genital infections, the UTIs, and then the volume depletion associated with that as it travels through the kidneys. There is a risk of bone fracture, and that is with the canagliflozin. There is an increased risk of LDL cholesterol, and that is of concern because remember that LDL cholesterol is our bad cholesterol. And then we have a risk of the Fournier's gangrene associated with the SGLT2s. There is a renal dose adjustment required for eGFRs, or remember the estimated glomerular filtration rates less than 60, and you should discontinue these drugs prior to any surgery because of the risk of DKA. And these drugs are typically of high cost for our patients. That is something to consider when prescribing. Let's move on to the DPP4 inhibitors. Now, these drugs are glucose dependent, and they increase insulin secretion and they decrease glucagon secretion as well. The drugs commonly falling under this class are sitagliptin, vildagliptin, saxagliptin, linagliptin, and the alogliptin. These are oral medications. They do have benefits that they are weight neutral, and they are typically well tolerated, but they do not show or evidence has not supported any effect, positive effect on the atherosclerotic cardiovascular disease or in patients with that condition. However, we haven't really noticed any worsening in that as well. Except for saxagliptin, which has shown some potential risk in heart failure patients. There is a renal dose adjustment required for the sitagliptin, saxagliptin, and alogliptin. There is not a dose adjustment required for the linagliptin, though, and that's important to note. It is of high cost, so these drugs that fall within this drug classification are high cost. It's important to realize that as you deal with patients and prescribe this or offer it as a form of treatment for patients. Let's move on to the sulfonylureas. We're talking about the second generation sulfonylureas. These drugs are glucose dependent. They do work in the pancreas to increase insulin secretion. Drugs that fall within this class are listed here and include the glipizide, the glyburide, and the glimepiride. These are oral medications, and they are neutral in the atherosclerotic cardiovascular disease patients and heart failure patients. They have some adverse effects in that they have a high risk of hypoglycemia and some weight gain, and there is some safety concerns. In fact, there's an FDA warning on increased risk of CV mortality based on older sulfonylureas, and you see the tolbutamide listed there in that, and that's where we find the evidence from that. We want to avoid these drugs altogether in renally impaired patients. They are of low cost, though, something to consider if the patient is having difficulty with finances. Let's talk about the TZDs next. TZDs improve insulin sensitivity, transport, and use in the tissues. They, especially in the skeletal muscles. We have PAHO, glitazone and roseoglitazone that fall within the TZD drug class. These are oral medications. They have some potential benefit to those patients who have atherosclerotic cardiovascular disease, and that includes the drug glitazone, and in patients with the non-alcoholic steatohepatitis or fatty liver, known as NASH. So there's some potential benefit there. There are some adverse effects associated with this drug class, including weight gain, and there is a black box warning for heart failure patients on glitazone as well as a roseoglitazone. There's a risk for bone fractures, bladder cancer with glitazone, and increased LDL with roseoglitazone. So a lot of adverse effects you need to watch for with the TZDs. It is contraindicated in heart failure patients and in patients with liver disease. And you have to avoid these drugs in patients with renal impairment due to the potential for fluid retention. And again, that's why it gets the bad rap, so to speak, with heart failure patients because of because it causes patients to retain the fluid. It is low to moderately high cost depending on which drug you're choosing there. Let's move on to the Glynides or the Glynides. These drugs increase insulin secretion from the pancreas. Glyninide and Glyninide are oral medications. They are usually not on the treatment algorithm that we find in our diabetes care. They weren't found this year. And when I say the treatment algorithms, again, those are the treatment algorithms developed by a consensus panel from the American Diabetes Association and the American Association of Clinical Endocrinologists. Every year they provide standards of care and guidelines that we use. They are currently not on the treatment guidelines for the treatment of diabetes. There is a requirement for renal adjustments for an estimated GFR of less than 30, and their adverse effects or disadvantages to this drug class include that it requires frequent or pre-meal dosing, and it does cause weight gain. And so given that, you can understand why that may not be on the treatment algorithm, because typically these drugs are used with type 2 patients. They tend to have a propensity for obesity as well, and so we don't want to cause extra weight gain in our patients. All right, let's move on to the alpha glucosidase inhibitors. These drugs work in the small intestine to slow down absorption of carbohydrates, and they decrease postprandial glucose excursion. Acarbose and miglytol are oral medications within this group. Sorry, lots of words here, farm drugs here to recite. These are oral medications. They do have a low risk of hypoglycemia. There is some, they are safe to use for our patients who have cardiovascular disease. The disadvantages include that you have to avoid them if the GFR is less than 30, and they do cause a lot of diarrhea and flatulence. They do require frequent and pre-meal dosing, actually with the first bite of every meal, but these drugs can be on the low end of of cost, but they can also creep up there to moderately high cost. All right, we've got the amylin mimetics next to talk about. These drugs slow gastric emptying, and they make you feel full because the gastric emptying is slowed down. Pramlintide is a drug that falls within this drug class. It is a subcutaneous injection. It does require injection before meals, and so you have to train the patient on how to inject. The benefit is that it does cause weight loss. Again, makes you feel full fairly quickly. It slows gastric emptying, and so patients tend to have weight loss with that. Now, it is a very high cost, and it may not be covered by insurance, but some patients who are motivated by weight loss may opt for these drugs in this class so that they can lose weight. And they may pay a little bit more out of pocket for the drug. Let's move on to the GLP-1 RAs. There are some short and long-acting versions of the GLP-1 RAs. They, regardless, as a whole, stimulate insulin release from the pancreas. They slow gastric emptying and make you feel full, and they decrease glucagon secretion. Now we have the exenatide, which comes in the short acting version, and then the extended release or longer acting version. We have dulaglutide, semaglutide, liraglutide, and the lixisenatide also falling in the GLP-1 RAs. These are mostly subcutaneous injection, and the frequency of the injection, or how often you're going to have the patients inject themselves, really depends on whether it's a short-acting or long-acting version. Some requiring daily injections, some requiring weekly. We use this in patients who have type 2 diabetes only because you have to have some production of insulin for these drugs to work. Remember that in type 2 we have insulin production, but it may be deficient in the amount or deficient in its quality, meaning its action is not what it should be. So these drugs target insulin production, so it's got to be there, and then it helps in the ways that I talked about earlier with the stimulating the insulin release from the pancreas. What's important to know then is remember, of course, is that in type 1 it's basically an absolute deficiency of insulin, so this is why it wouldn't be a good choice for our patients with type 1. Some benefits to the short and long acting, and again, I've included all of those in here just for the overall GLP-1 RAs. Benefits include weight loss, again, that feeling of fullness and the decreased gastric emptying contributing to that weight loss. It is dependent on glucose. It does have some benefit. The duglutide, the liraglutide, and the semaglutide have some benefit in atherosclerotic cardiovascular disease patients. It is neutral, though. Exenatide once weekly and lixenatide, or what we call Lixi, they are neutral in patients who have, in helping with patients who have atherosclerotic cardiovascular disease. It is what heart failure neutral, and that is important to know. There is no renal dose adjustment for liraglutide, the semaglutide, and the dulaglutide. So that's good news. Now, look over at the disadvantages, though. I've kind of tried to align these as we go across, but there is an FDA black box warning for the risk of thyroid C-cell tumors in rodents for liraglutide, albiglutide, duaglutide, and the exenatide extended release, as well as semaglutide. There are some GI side effects that are common, like nausea, vomiting, and diarrhea. Of course, go back to where it is impacting patients, which is in delaying or slowing down gastric emptying. So you can see those common side effects there. You want to monitor renal function with initiation and any increase in dose, especially if they're having the nausea, vomiting, and diarrhea, because with that nausea, vomiting, and diarrhea, they may have some fluid loss, volume loss, and then the dehydration, and then can worsen the renal failure or function. You want to avoid lixenatide as well as exenatide for GFRs less than 30. Avoid it in patients who have a history of pancreatitis, either acute or chronic, because of the risk of pancreatitis with it. There is a risk for injection site reactions as well. This is a very expensive drug, and it's often not covered by insurance. Again, some patients opt for it because of the weight loss advantage. So it's very important to discuss the financial situation of your patient with them so they can make an active choice in what they prefer as far as treatment. And here are some references that I used to put this slide deck together. It's a very brief overview, but I hope that you found it helpful. Thank you. Hi, this is Michele Talley, and today we're going to go through insulin use in patients with diabetes. Let me start by saying insulin is one of the top errored medications, and as nurses and nurse practitioners responsible for either the administration or prescription of insulin, it's very important that we ensure that the hospitals and institutions in which we work have protocols put in place to ensure the utmost safety for our patients. So I would like for us to remember that as we go through this presentation and think of ways in our own institutions that we can make things a little safer for our patients. I'm going to go through insulin, some of the benefits and the disadvantages, and I think this will help stimulate some of those conversations about safety and insulin with our patients. So here are some benefits to insulin. Insulin, human insulin, is actually a very low cost for patients. It is heart failure neutral, and we can use it in renal failure or in patients who have renal failure, but we must reduce the dosages for insulin because it is cleared by the kidneys. The disadvantages for insulin, though, are that insulin in general causes weight gain, and analog insulin usually is associated with a very high cost, and it is neutral when it comes to atherosclerotic cardiovascular disease. It doesn't benefit, but it doesn't harm patients who have ASCVD, but it is neutral there. We do see some insulin injection site reactions that do occur, and obviously there is a higher risk of hypoglycemia when we're talking about NPH and premixed formulation. We'll go into more detail of that in the future. So when we talk about insulins, I think it's important to think about honestly the different categories of insulin. The categories are typically related to duration, some on onset as well, but the duration of how these insulins act And we see those categories of rapid acting, short acting, intermediate acting, and long acting insulins on the left hand side of our slide. On the right hand side, you see the premixed insulin combinations, and then we see the premixed insulin combination with other injectables listed at the bottom. So let's go through some of these. Rapid acting insulins, Lispro, U100 and U200 are examples of rapid acting insulin. Glulisine and Aspart are other examples. And then we have some inhaled options for rapid acting insulin as well. Typically, rapid acting insulins are dosed every 4 to 6 hours. The onset is usually fairly quickly in 0 to 15 minutes, and that is why we can dose these rapid acting insulins right before a meal, because they will start acting very quickly and they will last about as long as we need them to for the consumption of that meal and for the peak in the blood sugars related to the meal that was eaten. So we also have a short-acting category. It's easy to remember that regular insulin is the only insulin that falls in the short-acting insulin category. And usually it lasts about 6 to 8 hours. And there are U100 and U500 versions or concentrations of this insulin. We have intermediate acting insulin, which is human NPH insulin, and that is the only one that is falling in that intermediate acting category. Then we have the long acting insulin category, in which glargine falls. It has U100 and U300 concentrations associated with glargine. We also have Detamir and Duglatec that fall into the long-acting category, and Dugladec, we have U100 and U200 versions of that. Again, the intermediate acting requires typically a 2-time-a-day or BID dosing and that is because of the duration of action of NPH insulin. It does require the 2-time-a-day dosing because it only lasts about 12 to 16 hours. We have the long-acting versions, glargine, Detamir, Dugladec, that are listed at the bottom of the slide, and typically those last a minimum of 24 hours, some up to 36 hours in their duration. Most of these medications have a flat peak or no peak associated with them, and they tend to work within 2 to 3 hours. Let's talk now about premixed insulin and the combinations there. I think it is very important to realize that we have mixes of insulin in rapid acting or short acting versions of the medications, as well as a longer acting duration associated with the mix. That's because we have a basic need for insulin at baseline, right? All the time. Whether we're eating or not, we have a basic need for sugar or energy in the body. Our cells need that, and we have to have insulin to help get the sugar out of the bloodstream and into the cell. Remember that insulin is the key that unlocks that cell's door and lets it out of the stream and into the cell. So we need both basal insulin or a longer acting insulin, right? And you see that in our combinations here, but we also need a rapid acting or a short acting medication in there so that when we eat a meal, we do have some coverage and a little bit more concentration when we eat those meals of insulin, so that kind of my scenarios, when we throw sugar at the body is able to have insulin to meet its need and then help that energy out of the stream and into the cell to be used as energy. The premixed insulins come in 70-30 combinations, 50-50, 75-25, and it's important to write those premixed combinations out as you prescribe insulin, but also important to pay attention to it when you order it. There are also premixed insulin and GLP-1 RAs that are listed here, the glargine and lixisenatide, which we call Lixi a lot of times, and then we have the Dugladec mixed with the liraglutide. So we have those injectable combinations as well. All right, let's talk a little bit more in depth here. Now, we have human insulin versions and analog versions of insulin. So that is one difference that we have. We have humulin and novulin insulin, and then we have the analogs like were mentioned in the previous slide for the rapid acting, the glulisine, aspart, and the lispro. And then we also have, and of course these come in rapid acting, short acting, intermediate acting, and longer acting categories. We also have the plain and premix, which I mentioned earlier, and I think that causes a lot of confusion with a lot of nurses and healthcare professionals, so be sure that you are aware if a medication is already premixed, and check orders frequently to ensure that it is plain or premixed. Look at both. Giving you an example as we go back one slide, aspart comes in a plain, and you see that over here as a rapid acting, and you also see lispro listed as rapid acting, but it is and does come in the premix combo. You also see NPH and regular falling over here into these two categories. So it's something to pay attention to so that you prevent errors in the future. All right, going back to the slide, insulin comes in a variety of administration methods, including subcutaneous, intravenous, and inhaled administration. We also have various technologies to assist with administration, like our sub-Q insulin pumps, our IV insulin pumps, our inhaled apparatus to help with inhaled insulin, our syringes, and our pens. We also have the concentration of insulin, which differs, and those concentrated insulins are listed as the U100, which is the standard, or U200. We also have U300 and U500 versions. Typically that means that we have 200 units in 1 ml. In the case of U200, for U300, 300 units in 1 ml, and U500 would be 500 units of insulin in 1 ml. And of course, the standard U100 be 100 units per 1 ml. Now, we can use insulin in any type of diabetes or even for hyperglycemia or hyperglycemic events, and we used to say that it was used in only type 1, and people would differentiate between type 1 and 2, meaning the use of insulin a lot of times. And that's really not the case, because our standards of care that are written and updated each year have produced over time evidence-based protocols for us. And we know now that based on the standard of care as outlined by a consensus guideline from the American Association of Diabetes, or American Diabetes Association rather, and the American Association of Clinical Endocrinologists, that right now we consider insulin as the first injectable when an A1C is greater than 10%, or blood sugars are greater than or equal to 300 milligrams per deciliter, when you have ongoing signs and symptoms of catabolism. And what we mean by catabolism there is that we have ongoing symptoms of the body burning other sources for fuel, instead of being able to retrieve that glucose that is in the bloodstream as energy. So when the body cannot utilize the glucose in the bloodstream because the insulin is not there to help it into the cell and be used as energy, the body will burn fat and muscle, and we call that ongoing signs, symptoms of catabolism, when we use and burn fat and muscle to get the energy we need for the cell so that our body can function. So we have ongoing signs and symptoms of catabolism with that hyperglycemia of greater than or equal to 300, or we are suspecting the patient actually has type 1 diabetes. We will consider insulin as the first line of injectable medications. All right. So insulin dosing. We need to, first, when we look at insulin and starting it in patients, we are to calculate a starting dose of insulin. I know that when you're in the hospital setting, the providers typically take insulin naive, meaning they come in the hospital, they've never been on insulin before, and they need insulin now. Maybe their A1C is above 10, maybe they have a bout of hyperglycemia, and we have some associated symptoms with that. We may start a calculating dose of insulin, but we may not start using the quote low and slow method. We may start them very quickly on a weight-based formula and get them started on that insulin very quickly. But I am going to go through the ways that you can start insulin during this lecture in the upcoming latter part of this lecture. So we want to start with a dose of insulin. Again, it's very important to ensure the safety of the medication you're ordering, so know the kinetics of the insulin you order. Be sure to explain that to your patients so they understand as well. And choose a method of starting and initiating the insulin, and then track your own results with patients. It's a good idea to have a registry that you keep or have your staff keep so that you can keep track of your patients and see how well they are doing and faring with your target blood sugars that you set for them, because that is an indicator of not only their success but your success as a provider in meeting those individualized needs. So starting insulin, the most convenient way to start insulin is to start the basal once a day. We can use a long-acting insulin category to meet these needs. We could even use the less favored intermediate acting insulin, the NPH insulins, or premixed insulins, the NPH plus regular, or some of the analog premixed insulins that I mentioned earlier, the Lispro and the Aspart 70/30, the Lispro 75/25, Lispro 50/50, or the Aspart 70/30. So again, less favored NPH because it does have a longer duration of action. It lasts a bit longer. It has a peak associated with it. Maybe not the duration is not what causes it to be less favored, but that there is a peak associated with it. So the drug does have an increase in its release, and as it does that, it can cause some hypoglycemic events, especially when used with regular, which is commonly used with NPH. And so we see the premixed, the same reason. You have that peak associated with the NPH, and then the regular insulin. Let me talk about the duration there. I remember from previous slides I told you the duration of regular insulin was 6 to 8 hours, but we eat meals usually every 4 to 5 hours, and it makes us a less favored method to use for mealtime insulin because it will last longer than the meal and when it's needed. So you can tend to have a stacking effect associated with the longer duration of action with regular insulin. And hence, if you've paid attention, you may have seen some hypoglycemic events around 2 or 3 p.m. when you're in the hospital and you're dosing regular insulin with meals at 8, 12, and 4 or 5 o'clock. So just keep that in mind as we talk through these things. Now you can add, the insulins can be added to metformin and other agents relatively easily. I would ask you to refer to the standards of care and treatment algorithms to identify those that you would need or should stop medications when you add the basal insulin. But typically we will add a 0.1 to a 0.2 units per kilogram per day for basal insulin. And we'll consider the blood sugar upon initiation as to kind of how we're doing there. And then you can titrate over days to weeks if the patient's not in the outpatient setting, right? You can give them a formula and say, if your fasting blood sugars are still not at your target level, increase every three days, which we'll go through in a moment. But perhaps you don't have that luxury of time because you've got a patient who's in the hospital. Maybe they've had an acute MI or myocardial infarction, and you need to get rapid glycemic control. And so you might start them on a basal bolus or a basal and mealtime dose, and you might base it on weight because you don't have that luxury of time. And so you'll titrate that very quickly to get it where you need it. So let's talk about insulin dosing, the low and slow method. I mentioned this earlier. This is when we want to start basal insulin only. Maybe we're starting this at home. We've got a little time to get the dosage right. And so we can instruct the patient on how to monitor their blood sugars like they have been doing, but it's especially important now that we're adjusting insulin. Have them test their fasting blood sugars, at least that, if not more. We'd like them to check it before each meal if they can, before when they first wake up in the morning, before lunch, before dinner, and before bedtime. And then we want them to share those glucose readings with us so we can make adjustments based on their basal insulin. So if we take a look at their average of the last 3 days of blood sugars, and their blood sugars are 115, based on the algorithm we have here, if their average was 115, we would add 1 unit of basal insulin to their current dose. So if the patient was on insulin glargine 20 units once a day and their average was 115, we would ask them to go up to insulin glargine 21 units once a day, sub-Q. So that's how you read that chart and how you apply that chart. Again, we want to start doses of 10 units of basal insulin each evening. Sub-Q, we would instruct a patient to take 5 units twice a day only if they were using the intermediate acting insulin category, or NPH, as their basal insulin. Otherwise, the other long-acting insulins would be our choices as basal insulin, and we would be, because those last at minimum 24, sometimes up to 36 hours, we would dose just once a day. It's important that we know as well that we're still, dosing that on and trying to stay at 0.1 to 0.2 units per kilo. And we want to reduce, the other thing I wanted to say was we want to reduce the basal insulin if we have hypoglycemic averages. So if we're averaging anywhere below 80, basically, we're going to want to reduce by at least 2 to 4, units of our basal insulin to ensure that the patient doesn't continue to have hypoglycemic events. All right. So insulin intensification, what if you're not achieving blood sugar control with your patient at home? Well, we can escalate the algorithm or increase the amount of medications that we're providing for them. Again, we could have them taking their metformin already. Maybe they are on a sulfonylurea or a DPP4, in which case we would ask them to discontinue it if we are adding insulin. I mentioned that earlier as well. So what our steps are annotated here. We would want to add the basal insulin and titrate to achieve a target blood sugar range. Our fasting blood sugar range is to be within our target level, or until we get to 0.5 units per kilo per day. The reason that is important is because basal insulin, our basic need for insulin that is there and present anytime that we are not eating, that is what we use our basal insulin for, is to help get the glucose out of the bloodstream and into the cell so it can be used as energy at all times. Now, what happens if we start to exceed 0.5 units per kilo per day? We may start trying to cover the meal time excursions or meals with our basal insulin, which is not what it's intended to do. Remember that our bolus or our mealtime or prandial insulins, which are our rapid-acting insulin categories, are what we need to be using to cover our mealtime excursions or breakfast, lunch, and dinner. So basal is for our basic need for insulin, and then anytime our blood sugars are increased with breakfast, lunch, and dinner, we want to use a rapid-acting drug category, It's going to last 4 to 5 hours, and it's going to have a peak, about the peak that our meal and our sugar peaks from our meal. So that's why we use those different drug classes. Again, we add one, so in order to avoid over-basalization, at the point you get to 0.5 units per kilo per day and you're not still where you need to be with your blood sugars, there's the time that you want to add your mealtime insulin. Start by adding it to the largest meal of the day that the patient eats, and ask them that, what's your largest meal of the day? Let's try taking some mealtime insulin then. And then we may need to intensify that so that they're using the mealtime insulin up to 3 times a day with meals. The other thing we can do, which is step 3, is to add a correction scale insulin to the regimen. Again, that would be a rapid-acting insulin. It would be added to the mealtime insulin to correct what is then an already abnormal blood sugar. So you have a basic need for insulin. If your basal insulin is dosed correctly, you should have normal fasting blood sugars. If you've got if you check your blood sugar and they haven't had anything to eat or drink with sugar in it before lunch, their blood sugar should be within the normal range, 90 to 130. Then we go to dinner, should be 90 to 130. Bedtime, 90 to 130. If you eat your meal, though, and let's say you eat breakfast and you don't have your mealtime insulin dose right that you're using, then you may see the elevation of a blood sugar before the patient even eats their lunchtime meal, their dinner meal, or before they go to bed. Now, in the case of correction insulin, most of the time it's dosed right before breakfast, right before lunch, and right before dinner, up to 3 times a day to correct an abnormal blood sugar before they even eat. But it is a rapid-acting insulin category. So if you have insulin Lispro that is ordered 2 units sub-Q with meals up to 3 times a day. Then you can add insulin lispro and a correction scale, which is individualized to the patient based on the sensitivity of the patient. Because remember that a correction scale or a sliding scale, not one size fits all, right? Because we're not all the same size. Our body is all different. So for thin versus obese patients, thin patients are more sensitive. Obese patients tend to be less sensitive to insulin. Those with renal failure are more sensitive rather than those who have normal functioning kidneys. So we need to individualize treatment based on the patient and the conditions of the patient. So let's talk about the insulin intensification a little bit more. Let's talk about that prandial or that mealtime method. And let's talk about adding those together, adding a bolus and a basal all together at once, and the reasons why that's important. We tend to have to use this when we don't have a lot of time to achieve glycemic control. In the case of a patient who is in the hospital and we want to achieve glycemic control very quickly, we don't have 3 days to look at average blood sugars. We've got to do something quick and start. So we look at the patient's kilograms. We do their weight in kilos. Then we multiply that times 0.5. Because remember, we don't basal insulin, we know it's about 0.5, right, units per kilo per day. And then we're going to give another, so we're going to multiply their weight, we're going to multiply it times 0.5, we're going to figure out how many total daily, what the total daily dose for insulin is, and then we're going to break that in. That's how we figure the total daily dose. And then the total daily dose is actually 50% of your basal dose and 50% of your prandial dose. I got ahead of myself just a minute ago, but notice that to calculate the total daily dose, we do the weight in kilograms times 0.5, and then we take that total daily dose, we divide it out so that 50% is for the basic need for insulin and the other 50% is for meals. But remember, we eat 3 meals a day, so we must divide that number by 3, and that's what we do in step number 4. And then in step 5, we add that correction scale, and again, remembering that not all people are the same and not all people are sensitive in the same way. All right, so adjusting the basal insulin. This is when you can use this when the patient is in the hospital and you're needing to make daily adjustments to the basal insulin based on the fasting blood sugars. You can look to the far left in the columns and see the fasting blood sugar listed there, and then the change that you would make to the basal insulin. Let's take a number, for instance. If we have 150 blood sugar, that was the average blood sugar that we had for fastings, and we had a patient who was on insulin glargine, and I'm going to make my math simple. Let's say that they're on 10 units of insulin sub-Q once a day and their blood sugars were 150, then I might increase, based on this chart here, the insulin glargine to 11 units sub-Q once a day. Okay, so that's how we read that chart, by increasing, and again, it's the basal dose by the percentage that it already is. So I hope that helps in adjusting basal insulin in inpatient setting. Now, typically, when you're looking at the bolus and mealtime dosing, again, mealtime insulin is usually taken immediately before, during, and after a meal. That's because it works in 0 to 15 minutes. It usually lasts 4 to 6 hours or thereabout, meaning breakfast, lunch, and dinner we space out about 4 to 5 hours, right? And that insulin is going to stay on board about the time that we need it to accommodate our glucose, increasing glucose, and then we're increase our insulin so that there's a match there. Again, insulin's going to go into the bloodstream, get the glucose out, put it into the cell, and we can use that as energy. I usually tell patients then, mealtime insulin is tied to the meal. If you don't eat the meal, don't take your mealtime insulin. And if you only eat half of your mealtime, your carbohydrates in your meal, or your meal, only take half of your insulin, your mealtime insulin. And if you've got things dosed right, if a patient is not able to eat or drink anything in the hospital and they're NPO, and you have basal insulin ordered and then you have mealtime insulin ordered, you would continue to give the basal insulin, but you would have them hold or not give the breakfast, lunch, and dinner insulin or mealtime insulin, because that's tied to the meal and they're NPO. Now you can also, so that's one method of teaching patients. You can teach them how to count carbohydrates, and that's for somebody who's really good and can mathematically calculate ratios like 1 unit of insulin for every 5 grams of carbohydrates. That requires them to know and how to read labels, but it also requires them to know whole foods, about how many carbohydrates are in an apple, a banana, that sort of thing, where there's not going to be a label present. So that's a lot. You have to determine the patient's health literacy and determine whether they would be able to calculate insulin and carb ratios. You could also use the percentage method, as I mentioned here. Now, patients that have insulin pumps also could use a percentage method, but typically if you're using an insulin pump, we want them to count carbs and use an insulin to carb ratio. All right, that requires a lot of advanced teaching, and usually recommend an advanced diabetes class to do that. So let's talk about basal bolus method, more specifically about the correction insulin. Now, I mentioned earlier, correction insulin should be individualized for patients. Again, it's not a one-size-fits-all type thing. And correction insulin is typically dosed according to a couple of things, considering the sensitivity, a patient's age, their kidney function, and then the size of the patient, or how much they weigh. Are they normal weight, overweight, or obese? And then maybe perhaps other conditions going on with the patient. You'll see what I mean when we talk through this. So a low dose algorithm for correction insulin includes a calculation for patients who are thin, elderly, or have renal impairment. The moderate dose is for the average size adult or normal weight. The moderate to high dose algorithm is for those who are obese, who have infection, or who are on steroids. And then our high dose algorithm is really reserved for those who are extremely insulin resistant or those who are septic. So a lot of times we don't utilize this unless they're in the hospital. Now, again, looking at each individual algorithm, let's pick it apart a bit. Now, we have BG, which stands for blood glucose, right? We have the current blood glucose minus the target glucose for a patient divided by a denominator or a number on the bottom, right? So we have to determine for our patients what that target blood sugar might be. Now, let's say they're at home and we want their blood sugars to be 90 to 130. We might choose an average of 120 and that would be the number we use as the target glucose. All right, now if they're in the hospital, perhaps we're shooting for the 140 to 180 range, we might choose 150, 160 as our average glucose that we would put into this formula. But as you can see here, we've chosen 120 to put into our calculation. We take the current blood glucose of the patient minus the target divided by the sensitivity of 50 if it's low dose. Okay, so let's take that, pick that apart then. Let's say the current blood sugar is 220 and we want our target to be 120. So we take those two numbers, 220 minus 120, that gives me 100. 100 divided by 50, I would give 2 additional units of my rapid acting insulin with or before the mealtime insulin. Okay, so before the meal, but with the mealtime insulin. So let's say I have insulin Lispro that I use for a patient, and they take 4 units sub-Q of insulin Lispro up to 3 times a day before meals. The patient's about to eat. The blood sugar was 220, as I mentioned. We're using the low dose formula because maybe it's a 80-year-old thin female. And so 220 minus 120, 100 divided by 50. Again, I've got my 2 units. I add those 2 units of insulin Lispro that I'm using for my correction scale, add those to my insulin Lispro 4 units that I'm using at meals, and that gives me a total of 6 units of insulin Lispro that the patient can inject prior to eating. Now, that combination should do 2 things. One, it should fix the abnormal or elevated blood sugar that is occurring before the meal. And then the mealtime insulin of 4 units, if dosed properly, as we have, it should cover the mealtime, quote, excursion. So then we have a great way to kind of keep the blood sugars in a normal limit, or hopefully we have, and we'll reach those targets after and when we check the blood sugar again, perhaps before dinner. So remember that the correction scale is used in conjunction with mealtime insulin, typically, if the patient is eating, and it is dosed according to various factors influencing sensitivity. You do see the formula at the bottom, and I state that the the red highlighted number is the numerator, and that's your target glucose. And the denominator is the sensitivity factor. The higher the denominator, the less insulin that the patient will actually receive. All right, let's talk through insulin dosing using NPH and regular insulin. I mentioned earlier that it's the less favored method, reason being it's really only and works well with patients who have consistent amounts of exercise or activity, eat consistent meals, evenly spaced apart, typically 4 to 5 hours, and they don't have any other conditions that may exacerbate their diabetes, causing some stress, hyperglycemia, and their emotional stress stays at a normal and consistent level. Because NPH does have the peak, it is associated with some hypoglycemia. And then, as I mentioned, also regular insulin also has a peak. So if you're not eating consistent meals or anything comes into the mix there with emotional stress or a change in the exercise pattern, meaning you exercise more, it may not, the insulin and the blood sugar match may not occur, and there may be a mismatch. And then you have hypoglycemia or hyper. There's very little titration that you can do in the middle of the day to fix things. And so we see that we can quickly titrate using a correction scale and that sort of thing using a basal bolus method. We do not have that flexibility with NPH and regular or premixed insulins in general. All right, so let's talk about how we dose them. To dose them, we take the total daily dose. We've got to figure the total daily dose, right? That's based on 0.5 units per kilo per day. And again, this is when we're trying to start them on something very quickly. We don't have the luxury of titrating to effect. So 0.5 units per kilo per day. And that's the patient's weight in kilos per day, in kilograms. And then we take the total daily dose, we divide that so that we give 2/3 of the total daily dose in the morning and the other remaining 1/3 in the afternoon with the afternoon meal. So what I mean afternoon or evening meal, what I mean by that, you might take the 2/3 of the morning dose with breakfast, and then we will take the remainder of the dose with our dinner or evening meal. So look at our example here. We have a 70-kilogram patient, and he receives 35 units as his total daily dose. And we divide the total daily dose out, where 2/3 goes to the morning and 1/3 goes to the evening meal. That gives us 23 units total in the morning and then 12 units in the afternoon. Now, just in case you did not have a premixed insulin that you were using and you had prescribed, or the patient was taking NPH in a vial and then also regular insulin, they had a different vial and they had to mix the two. Remember, we would go with fastest first as far as mixing, but when you do have to mix, you can see that you'll have to calculate slightly different. Those calculations are indicated in parentheses in step 3 and step 4, and then they're also indicated at the bottom. So you give the 2/3 of the dose. We know that's 23 units that we would be giving in the morning if it was a premixed insulin. If it's not a premixed insulin, the patient has to mix it themselves, which requires a great deal of teaching. It would be 15 units of NPH with 8 units of regular insulin with the morning meal, breakfast meal, and then in the afternoon meal or evening meal, when you have 12 units that they're to take, you're going to give 6 units designated to NPH and the other 6 units from regular with that evening meal. So that does require a little bit more teaching and calculation on the provider part as well. All right, so let's take a look at why we might use NPH and regular premixed.
let's say we have a patient, he is in the hospital. He says that he is willing to take 2 shots a day because we're going to want to talk with them about what they're willing to do, what they're able to do. And in assessing his financial and insurance situation, you know he's uninsured and he makes less than $20,000 a year. In your conversation with him, you need to discuss how much insulin is going to cost and how they will be able to afford it. So looking at this, you say, okay, you're going to take 2 shots a day. Well, what I need you to do then to make sure that this is safe for you to do, I need you to eat regular meals. I need you to eat 4 to 5 times apart, hours apart. I need you to take 1 dose with your breakfast meal and 1 dose with your evening meal. Are you willing to do that? Let's say they say yes. So then we calculate the insulin. So how do we calculate the insulin? Well, we're going to take the total daily dose. We're going to multiply to 0.5 kilos, 0.5 times the kilograms per day, and that will give us the total daily dose. Remember, the kilograms is the patient's weight in kilograms. And then once we get that total daily dose, we will divide it out, as mentioned in the previous slide, where 2/3 goes to the morning meal and 1/3 goes to the evening meal. And that's our premixed insulin. We'll have to do a lot of teaching with that as well. I hope that this helps with your understanding of insulin, and I hope that you have found the information here to be helpful.
Hi, I'm Michele Talley. I'm going to go through diabetes and acute complications during this presentation. Let's get started. First, let's go through what some normal blood sugars are at home. Normal blood sugars at home for patients with diabetes include a target of 80 to 130 milligrams per deciliter before meals, and that's what is meant by preprandial. Now, the highest a blood sugar should be after eating or postprandial should be 180. So we always want to keep blood sugars less than 180 milligrams per deciliter. Now, target blood sugars in the hospital are a little bit different and sometimes depend on the reason the patient is admitted or any procedures they're having. But our basic things are that we want to avoid hypoglycemia and hyperglycemia while they're in the hospital. Typically, hospitals identify protocols that are run by specialty teams or glycemic control teams to help aid in this control of blood sugars while patients are hospitalized. Let's talk about hyperglycemia first. So with hyperglycemia, we define this as greater than 140 milligrams per deciliter when a patient is in the hospital. And typically, we start insulin when blood sugars exceed or are equal to 180 milligrams per deciliter. Now, after we start insulin in the hospital, our target becomes 140 to 180 milligrams per deciliter for the majority of our critically ill and non-critically ill patients. Let me mention at this point that the standard of care hasn't changed in the last several years, which includes that we should stop all oral medications and most injectables besides insulin when patients are admitted to the hospital, for various reasons like interference or interaction with contrast dye or things that may be worsened, conditions that may be worsened with some agents used for diabetes control. It is best and safest to stop these oral medications and other injectables when a patient enters the hospital, especially if they're on something other than insulin. Now, if they're on insulin, we want to continue that. If they took an oral or injectable at home, then we'll want to stop those and then transition them to insulin therapy while they're in the hospital. Now, let me move along. If we need tighter control of the blood sugars, and typically this is within patients who have had a cardiac surgery, and we want to keep closer or tighter control of the diabetes, then we'll try for a target of 110 to 140 milligrams per deciliter. And again, we only want that to be our target within this specific population if we're able to avoid significant hypoglycemia. Now, 180 to 250 milligrams per deciliter may actually be acceptable in patients with severe comorbid conditions or where close nursing supervision is just not possible. And we will accept blood sugars or tolerate blood sugars greater than 250 milligrams per deciliter in patients who are terminally ill in our hospitals. All right, Let's talk a little bit more about patients with diabetes or those who present with hyperglycemia to our emergency department or initially as a direct admit to our hospital. They need to have a hemoglobin A1C upon presentation. The reason being is that we want to determine whether the patient has had pre-existing diabetes, if they have hyperglycemia that we note in the emergency department or upon admission, or if it is diabetes that has been poorly controlled. Now, if they haven't had an A1C in the last 3 months, one is indicated if they have diabetes, or if they come to your hospital and they have hyperglycemia and have never had one, that's the time to get one. Again, this aids in determining whether this is a new onset of diabetes, or if it is a pre-existing, obviously, but also if a patient comes in with hyperglycemia, have they been running a high A1C the last or 3 months ago and they're still hyperglycemic upon presentation, or is one of the problems as they're coming in, the hyperglycemia, the presenting problem and all the other symptoms, are they associated with that hyperglycemia causing an emergency? Now, I mentioned this earlier, but we do need computerized insulin order sets and protocols. These are usually institution specific or hospital specific. And again, this current recommendations are that we use a specialized glycemic control team to aid in the care of patients who have either hyperglycemia or diabetes, because that is, we want to tap into those experts so that we can prevent hyperglycemia and hypoglycemia while in the hospital and aid the patient in recovering as quickly as possible for whatever caused them to be admitted in the first place. All right, so there are 2 types of hyperglycemic emergencies. I'm going to talk about them briefly here. The first is diabetic ketoacidosis, known as DKA. The second is hyperosmolar hyperglycemic states, or HHS. You may have heard this termed hyperglycemic hyperosmolar non-ketotic states in the past, or syndrome in the past. HHNS was an abbreviation used, or HONK, HONK was another abbreviation that was used. Again, all of those abbreviations and terms used to describe hyperosmolar hyperglycemic state, HHS, which is what I'm going to talk about here. Now, there are variations from euglycemia to mild hyperglycemia with acidosis to full hyperglycemia, or severe, I don't know why I just said full, but severe hyperglycemia with dehydration and coma. So there are wide variations in DKA and HHS related to this hyperglycemic emergencies. But the goals of treatment remain the same. We want to restore circulatory volume because these patients are typically dehydrated, and we want to restore tissue perfusion. We also want to resolve any hyperglycemia that is occurring and treat with continuous IV insulin when the patient is critically ill or obtunded. Otherwise, if the patient is in mild to moderate DKA, we can treat with subcutaneous insulin. Again, another goal of treatment is to correct any electrolyte imbalances or acidosis that may be present and to treat the underlying cause. So let's talk about DKA. It's mostly occurs in our patients who have type 1 diabetes, but 1/3 of the cases occur in those patients who have type 2 diabetes. And hyperosmolar hyperglycemic states are actually fairly common, but they are the most dangerous due to the high mortality associated with these states and states of emergency. Now, to differentiate between DKA, I like to talk about kind of the D and the K and the A and help you remember these things. But in DKA, patients are typically dehydrated, they're ketotic, and they are acidotic. Another thing that I like to mention at this point, as you look at patients who have DKA, you want to determine the reason that they're presenting either to your emergency room, your clinic perhaps, or being directly admitted with DKA. Why are they being admitted? Again, treating or drilling down to the underlying problem. It can be due to the 5 I's. It could be due to infection, ischemia, infarction, intoxication, or ignorance. And when we talk about ignorance, we're not talking about a low IQ, but rather we're talking about someone not knowing what to do because of a certain condition with their diabetes. Maybe their blood sugar is high and they don't know how to fix it. Maybe they're sick and they didn't know about the sick day rules, or maybe they just forgot to take their insulin and didn't know how to troubleshoot through that problem. So that's the ignorance I'm speaking of here, not necessarily a low IQ. It deals more with health literacy of their current diabetes condition. All right, so let's talk about DKA classifications first. They're classified based on the severity of the metabolic acidosis. So looking at the blood pH, the bicarbonate, and the ketones, and then the presence of the altered mental status. So in mild DKA, the pH is 7.25 to 7.29 and or a bicarbonate of 15 to 17.9 millimoles per liter and an anion gap or an AG greater than 10. Now with moderate DKA, you have a pH of 7 to 7.24 and or a bicarbonate of 10 to 14.9 with an anion gap greater than 12. And then in severe DKA, you have the DKA, which is complicated with a conscious disturbance known as DKA coma, or an arterial pH less than 7 and or a blood bicarbonate less than 10 with an anion gap greater than 12 without DKA coma. All right, let's look at DKA versus the HHS. So as we look at this, we look at the differentiating factors between the two, and those are listed on the left hand of the slide. Glucose is one. In DKA, you could have a blood sugar greater than 250. In HHS, they're usually and typically higher, sometimes greater than 600. Remember that there are varying states of DKA, and you could even have euglycemia or normal blood sugars still have DKA. That's why it's important to look at the other factors there. Look at the arterial pH. There is a difference here as well. DKA, typically the pH is going to run between 7 and 7.3. Again, varying states there. And then with HHS, typically the pH is greater than 7.3. With your serum bicarbonate, you have a 15 to 18 range for DKA, greater than 15 in HHS. With ketones, as relates to urine, you do have some in DKA, and that can have varying ranges, but you should have a small amount in HHS because it's not typically known by ketones or ketotic states. And then serum ketones would be positive in DKA, again, varying states there, but you should really not see very many serum ketones in HHS. Your serum osmolality is listed there. It could be variable in DKA, but typically greater than 320 in HHS. And your anion gap is greater than 10 to 12 in DKA, typically less than 12. Again, you do not have an anion gap typically with HHS. And then with alteration in sensoria, you could be anywhere from alert to a coma with DKA, but with HHS, you could have and typically have stupor and coma associated with the sensoria. Let's move along to the prevention of hyperglycemic emergencies because this is crucial to the success of treating the hyperglycemic emergency. So prevention is the key. Remember, I talked about the health illiteracy related to the healthcare condition of having diabetes, a chronic condition. So there are things known as sick day rules. We want to be sure that whether our patient has type 1 or type 2, that we go through the sick day rules because regardless of which type of diabetes they have, they could have either DKA or HHS as a result of uncontrolled blood sugars. So be sure your patient is instructed that they should take their medication unless otherwise told to do so, and that this may need to be adjusted. We want to ensure that our patients continue to eat and drink properly. So we want to tell our patients, if you're unable to eat and drink, or if you're able to eat and drink, please do so. And if you can't eat your regular meal, please do that also. But because we're concerned that you may have some dehydration associated with higher blood sugars, be sure to add a cup of non-caloric, so no-calorie fluid, every hour while awake. And examples might include broth, bouillon, decaf coffee or tea, sugar-free sodas, and water. And let me explain what I mean by sick day rules at this point. This might include something like a fever, the flu,
certainly COVID, certainly any nausea or vomiting that may be occurring, or diarrhea. So anytime someone has any of these conditions, you want to be sure they know how to take care of themselves to prevent that hyperglycemic emergency. Again, if the patient can eat, have them eat and do the non-caloric fluids. If they cannot eat their normal meal, we still want to be sure that they have sugar in some form, okay? And so in addition to the non-caloric fluid every hour, we want to add one of the following. And those items are listed here. This is the calories. So this is the sugar that the body needs. Remember it all the time. The body always needs some sort of sugar that can be converted, or glucose that can be converted to energy for the cells. So this can come in the form of a half a cup of apple juice, regular soda, a slice of dry toast, a half a cup of cooked cereal, 6 saltine crackers, a cup of sports drink, or a half a cup of regular ice cream or gelatin. And then we want the patients to check their blood sugars every 4 hours. We want them, if they have type 1 diabetes, to check for ketones, maybe every 4 hours as well, and to keep a check on their temperature every 4 to 6 hours, making sure they don't have fever, which again could be a reason they're sick, having infection. We want them to call the provider if they have diarrhea or vomiting for more than 6 hours. If they have small or moderate ketones in the urine and they have type 1 and are checking those. If their blood sugars are greater than 300 on at least 2 occasions, and their blood sugars are less than 70, or they have a fever of greater than 101 degrees Fahrenheit. So let's talk about hypoglycemia now. Hypoglycemia is defined as a blood sugar less than 70. You have 3 levels of hypoglycemia. Level 1, of course, we're going to treat them based on these different levels. But level 1 hypoglycemia includes blood sugars between or equal to 54 and 70. And then we want to treat that with glucose. And then level 2 hypoglycemia is less than 54 milligrams per deciliter. And in this case, we want, a lot of patients could be unaware of their hypoglycemia or of their blood sugar being low, and will typically want to treat them with glucagon. Maybe they are just, not aware that it's, have no warning symptoms that it's low. And then level 3 hypoglycemia may be a severe event with altered mental status and or physical functioning, and we want to treat with glucagon. And typically in level 3 hypoglycemia, this requires another person to recover from. So let me go through what we call the rule of 15. I think this is very important as a provider for you to know, but also to teach your patient. So if you have a blood sugar that is less than 70, it's important that we give 15 grams of carbohydrates every 15 minutes until the blood sugar is above 70. That's why we call it the rule of 15. So in the rule of 15, blood sugar is less than 70, we give 15 grams of carbohydrates. Again, this might be 4 to 5 ounces of regular soda, juice, glucose tablets. It may be glucose gel. But at any rate, we're giving 15 grams of carbohydrate. We're checking the blood sugar again in 15 minutes. If it's still lower than 70, we're doing it again, 15 grams of carbohydrates. Once that blood sugar comes up above 70, we're going to instruct the patient or provide them with a snack or a meal. And what I think is important over to the left-hand side is this. If the patient is alert and the blood sugar is less than 70 or equal to 70, then they can take oral agents, meaning they can swallow without any difficulty, can converse with you, you feel comfortable with that. Give them that 15 grams of carbohydrates by mouth, check their blood sugar in 15 minutes following the cycle. However, if the patient is unresponsive or cannot swallow, in the hospital, your hospital protocol is usually going to have you giving D50, an amp of D50 and half an amp of D50, typically glucagon, and you can give glucagon injections, 1 milligram IM or subcutaneously, and you can even give intranasal glucagon now. So check your hospital protocol. If you don't have one, borrow that evidence-based practice from somewhere else and institute one in your hospital or facility. And Always, if the patient is unresponsive and cannot swallow, they need a rapid response called, a code called on them, or if they're at home, to initiate the emergency medical services, or EMS. I think it's important that we teach families, especially and friends, those who live with patients who have diabetes, to use the monitor, use their glucometer to identify hypoglycemia, and to know how to, quote, rescue the patient in the case that the blood sugar is less than 70. Now, I do want to go back as I close. I do want to go back and I do want to talk briefly about the 5 I's again, recognizing that hyperglycemia is caused typically from one of the 5 I's. Again, that's the infection, the infarction, the ischemia, the intoxication, or the ignorance. Those 5 I's can occur with any hyperglycemia. Again, high blood sugars can be caused by the 5 I's. Typically, the ignorance is health illiteracy related to the chronic condition. But when a patient presents, you're going to want to go through those 5 I's, regardless if they have DKA or if they have HHS. Go through those because you're going to want to treat the underlying condition. Again, prevention is the key. Prevention is the key for hypoglycemia and hyperglycemia, and teaching patients those sick day rules and how to rescue themselves using the rule of 15 is crucial. Thank you for your attention. I hope you've enjoyed this presentation.